Good morning, everybody, and welcome to our panel, Primary Care Evolves. We are delighted to have you. It has long been clear, and I think self-evident, that those who have regular access to a primary care physician who actually utilize that access have longer lifespans and health spans. Yet what seems obvious to say, and I think almost clearly self-evident, does not necessarily align with the continued challenges that many, including our three distinguished panelists, face as they seek to improve in America with just a better health forecast. I have here on stage three leading lights in this space. We're going to talk a lot about just all the challenges that we're seeing in primary care today, whether it's decreasing incentives that seem to winnow by the day for a trainee that maybe is in Dr. Schuster's graduating class to enter the space of primary care medicine. Or whether it's the ways in which technology is redefining patient engagement literally every single day. So joining me to help provide situational awareness on the current state and a roadmap for the future are Dr. Toyin Ajayi, founder and CEO of CityBlock, founding dean and CEO of the Kaiser Permanente Bernard J. Tyson School of Medicine, Dr. Mark Schuster, and the president of the Commonwealth Fund, Dr. Joseph Betancourt. Thank you all for being here. I should note we're going to have time for audience questions at the end, so we'd love to hear from you. So please do think about anything that you'd like to ask the panelists. I do want to start. So we're going to start with a situational awareness overview. Where are we right now? I think we're going to tread an understanding. I'd love to hear from all of you on current state, then move into some discussion on where are we headed, and then end with technology and integration of technology within just the day-to-day of a primary care physician. So that's going to be the structure. For all of you, and let's start with Toyin and then perhaps Mark and Joe, I'd like your thoughts as we start out on why it is that even somebody that's insured, has durable insurance, particularly younger generations, why is it that we're seeing that fewer and fewer people are actually engaging with that access? Why are fewer people not even seeking primary care utilization for non-emergency care? I'd like to explore that trend first with you, Toyin.
Sure. Well, first, it's such a privilege to be here with you all. I'm really excited for this conversation. Maybe a disclaimer before I start. Just my remarks are entirely sort of colored and shaped by the space that I focus in, which is caring for people with complex needs, physical health needs, social needs, behavioral health needs, and folks who are living with the sequelae of poverty. So I focus on populations in Medicaid and people who are dually eligible for Medicare and Medicaid. That's my world. And so when you think about access to care, the major barriers that we're seeing are the fact fundamentally that our healthcare system has not evolved to meet people where they are today. The way that most healthcare providers deploy services looks exactly the same as it did 30, 40 years ago. You have to leave your home, make an appointment first, well in advance. We're seeing wait times of weeks and weeks and weeks for a routine primary care appointment. You have to leave your home, take time off work. For many of my patients, that's cash out of their pockets. Find someone to watch your kids, pay for transportation, go to sit in a waiting room. Wait times are often on the order of an hour or two. If you are someone who struggles with mental health, you have to expose yourself to the risk of being dismissed, of being treated as though you don't belong there. If you're someone who struggles with houselessness, you have to deal with all of the challenges around the stigma associated with your social condition. You sit in a waiting room with a bunch of other sick people, and you get, if you're lucky, 10 minutes of someone's time. And certainly, if you're lucky, you come out of that experience maybe feeling barely heard at best. That doesn't work for our population. It doesn't work for anyone. It particularly doesn't work for people who are struggling with the complexity of the challenges that go along with poverty and with complex physical and mental health needs. And so folks choose not to go. We also know that we as a healthcare system, there was a panel yesterday that talked about trust. We have not done a good job of engendering trust with this population. We erode trust every time we ignore someone's concerns, every time we talk about them in disparaging terms when we think they can't hear. We talk about our non-compliant patients and our diabetics and our folks who are struggling with houselessness as though they are not as worthy of the respect and the dignity that the rest of us are. That matters, and it translates into folks avoiding the healthcare system because they know that they are exposing themselves to harm, actually, that is often imparted by the very people who are supposed to be helping them. And so we have a lot of challenges here, both around the structural infrastructure and the way that we deploy care to enable us to earn back the trust and meet people really where they are, with a full consideration of their social and their physical and their mental health needs in order to start to build that back together.
Mark, your reaction?
Yeah, I'd say that was a remarkably complete answer. That was fantastic. I'll just add that you start off by talking about people who are insured. Insurance is not access. It's necessary but not sufficient. In addition to all the challenges that people face with you can't get an appointment, it takes 6 weeks to get the referral, pre-authorization, prior authorization, you're denied and you're denied and you're denied. People can't manage all that. We need care coordination in our practices to help our patients manage this incredibly complex system. But the other thing I'd add is that we don't have enough primary care providers. We have a third of primary care physicians are 60 or over, and as someone who's working in a med school, we are not replacing. Medical students are being discouraged from going into primary care. They're seeing their potential role models burned out, depressed, talking about leaving practice early. They especially got this during the past few years with COVID, but even before this was an issue. There's a lot of challenges in primary care right now. I think we really need to work on reimagining, redesigning primary care, and I don't want to say we're starting from scratch. There are a lot of entities around the country that are putting together primary care practices that are groups that include not just physicians, but it's a whole team. We need teams of physicians and nurse practitioners and physicians assistants, now being called physicians associates, and medical assistants, community health workers. We need whole teams to work together to provide the care. I, as a physician, should not be going through all the detailed paperwork. I'm not good at it in any way. You want a team to work together with each person using their best skills to provide jointly the best care possible for our patients.
Well, so low supply, Mark, you touched on that. Toyin, you touched on the full gamut of challenges, but frankly, a suboptimal experience. Joe, I'm wondering, you're an internal medicine physician. You lead the Commonwealth Fund. You inform us all. What are these inputs I think we've known? What's the solution?
It's about investment. I mean, I think we need just to take a step back and have the humility to look at how we perform internationally. So if you compare us to other developed nations, we end up spending more. So it is not about not having money in the healthcare system and getting less for that money, with lower life expectancy, highest infant mortality, maternal mortality, disparities, chronic disease. So we start there. Then we turn and say, what's different about them than us? Above the issue of coverage and single payer in many cases, we look at the primary care investment. Those nations on average spend around 14% on primary care, whereas in the US, we spend around 5 to 8%. Primary care accounts for about 35% of clinical visits, yet 5% of healthcare expenditures. So really what we have is the perfect storm. We're talking at the level of access, and coverage does not meaningful access make, but it really is fundamentally about the investment we put in primary care and how that relates to all these issues of access and care, continuity. There's no doubt that we're in a bit of a perfect storm right now as it relates to primary care. Underinvestment, a workforce that's aging and certainly not being replenished, and I would argue a workforce that's highly demoralized for a lot of different reasons. I'd say for me, as a practicing primary care doctor, coming out of COVID was the worst of times for all the things we know, but it was the best of times because we were saving lives every day with many of the bureaucratic barriers stripped apart and the resources we needed at that moment to do everything we could to save people. We all come out of that, and now we're back into the same old, and it's really demoralizing. So that perfect storm creates these access challenges, it creates these disparities, and I think we really need to have some honest discussions about where you began. Primary care is, and it can take a lot of shapes, it will evolve, but it is the anchor for prevention, for addressing chronic disease, for addressing disparities. It is well known, the evidence is clear, And so we as a nation have to be more serious about it. And it's not that we don't have the money in the healthcare system, it's how we deploy it more in a more smart fashion.
That's great. I do. So we're starting, just for those that are joining in, we're focusing on current state, situational awareness. We have 3 leaders in primary care across the spectrum, different verticals, but I think interrelated. I do want to challenge for solutions here. So you've all touched on supply demand, not enough primary care providers in the pipeline. What do we do about it? And I'm going to start, Mark, with you. How do we incentivize your students? Is it more money? Is it better career opportunities? A diverse FTE? Help us understand that. And then Toy and Joe, would love your perspectives.
Yeah, well, I think the first thing is for folks to stop saying, you're too smart to go into primary care.
Oh.
I mean, that was being said when I was going into pediatrics, but it's still being said now, and even more forcefully. We need to laud primary care. It is intellectually challenging. You have to know all the different organ systems. You have to know all the specialties. You have to be able to take someone who has symptoms, and you're like, what is this? You're a detective. You're figuring out what's going on with this patient. This is something that is really challenging, and we should respect primary care. And that it goes hand in hand with something you just said, Vin. Payment. Joe's right, there's certainly enough money in the system, but the way we reimburse is such that primary care providers make a lot less. We don't pay for cognitive activity. We don't pay for taking a really detailed history and finding out that a woman is being abused, and that's the reason she's there for headaches. We pay in a way where you see her for 10 minutes and you give her some medication and you miss everything. So I think we really need to change how we pay primary care providers. I think obviously all physicians are paid well in terms of society, but relative within the system. And when I've got students and they come in wanting to go into primary care, but then they start being told, you'll make 3.5 times as much if you go into orthopedics rather than pediatrics or internal medicine, it takes time, but they start to give in to those possibilities. So I just think we do need to, as a profession, provide more for our primary care providers. But I also think prospective payment is at least one approach to take, meaning rather than pay for each test you do, each procedure you do, pay for taking care of a patient for a certain amount of time. And there's all sorts of jargon that goes with this, risk adjustment, patients who are likely to be sicker, you get paid more. But incentivize us so that we are providing holistic care for the patient. We are responsible for the patient's full health, rather than having us focus on, well, if my nurse practitioner sees this patient, we're going to bill less than if I see the patient. I'm not going to take the patient's phone call because I don't get to paid for it. I'm going to make them come in when, of course, I should take their phone call, and that would be best for them, best for me, and best for the healthcare system in terms of utilization.
Yeah, I couldn't agree more. And I think it dovetails really closely, I think, with what we're trying to build at CityBlock, but certainly where I think the world needs to go, which is essentially paying for outcomes and recognizing, because once you take that frame and look back and say, okay, we're focused on outcomes, we're focused on quality, we're focused on access to care, we're focused on reducing avoidable spend in the healthcare system, keeping people out of the emergency room in the inpatient setting if that's possible to be avoided, then suddenly the calculus shifts, and that primary care visit is really, really, really valuable, because that could be the visit that prevents a person from having to go to the hospital with a heart attack or with a worsening of their pneumonia. And so those alternative payment models, those ways of incentivizing care that align around value and outcomes as opposed to around transactional pieces of often procedure-driven experiences is really important. It allows us to reimburse primary care effectively, and certainly underpins the models that we've been really building and scaling at CityBlock. I think the other thing that's really important to touch on, and you touched a little bit on it, Joe, is the sort of crisis of morale amongst primary care providers. And you know, a lot of psychologists have been talking about this as moral injury. The idea, and this is really interesting sort of historically, this term was coined many years ago, actually, when looking at returning veterans from the Vietnam War. And psychologists found that the level of trauma and PTSD-like symptoms that were exhibited by these returning veterans far exceeded their exposure to real, actual violence. There was something disparate about their experiences of war and the trauma that they were left with. And what they hypothesized and then validated over time is that when you are fighting a war, when you are doing work that should be valorous, but that is personally costly, you are taking life is being taken, and you do not fundamentally believe that it is just, or you don't fundamentally believe that you can get the outcomes you're seeking, the trauma you experience is greater. And that's what is happening to primary care providers right now. They're working 10, 15, 20 hours a day, seeing 30 patients. They're charting in the evening and the weekends. They're missing time with their families. They're watching their colleagues from med school who went into orthopedic surgery or dermatology, no shade to you all, buying their third and fourth house, and they're wondering how they're going to pay off their student debt. And they're asking themselves, why am I doing this? Their communities are not healthier. They're admitting and readmitting and discharging the same patients over and over and over again for the same problems. It is morally deleterious to us to do work that feels futile. And that's what's happening in our system, because we are actually not set up to break that cycle, particularly when we're talking about things like poverty, homelessness and houselessness, hunger, racism. I actually think that healthcare can address those issues. Primary care can address those issues, but we have to have the time and the resources and the space and the infrastructure and the teams to do so that our clinicians can operate in a system that is empowering and enabling of them and is fulfilling. And then I think the final thing I have to say, given where we are in our sort of political landscape, is the decision that the Supreme Court made about affirmative action in higher education is devastating. Because the thing we have to also recall is that concordance in terms of your care provider is incredibly important for outcomes, particularly for Black and brown people. And what I mean by that is that the proportion of physicians in primary care and psychiatry and pediatrics who look like the people they are serving is an important fundamental input to healthier communities and better outcomes. And when we have eliminated our ability structurally to ensure that we are matriculating people from communities which they then seek to serve, people who look like me and who look like the patients we're serving, we are taking away a fundamental tool in addressing health outcomes and improving primary care. And so we have to talk about that.
Hear, hear. Hear, hear. Joe, I'm going to come to you in a second to have a quick follow-up. Give us an example of how Study Block is managing all the various solutions that you just proposed.
Sure, very quickly. And so we operate in value-based contracts. So that means that we do not get paid for a doctor's visit or a therapist visit or a procedure that we do in the office. We get paid on a total population basis, a lump sum that is predicated on us improving health outcomes. And we measure those in 3 ways. We measure, are we reducing avoidable hospitalizations? You all know it costs a lot more money to go to the ER to get your asthma inhaler refilled than it does to go to the primary care setting. And so can we shift medical spend away from avoidable hospitalizations and into the community? So we get paid on that, reducing the spend. We get paid on improving quality. And we look at typical quality metrics. Are people getting their treatment for hypertension, for diabetes? Are folks getting mammograms for breast cancer screening? Are we closing the gaps, particularly from a disparities perspective between Black and white communities, as an example, in those key metrics? And then we get paid on engagement, because you can't actually move outcomes if you haven't engaged people, if you haven't built those relationships and engaged them through the healthcare system. And what that allows us to do is to invest in a full multidisciplinary team that includes mental health providers, community health workers, pharmacists, nurses are critical, as well as primary care doctors and other providers. And it allows us to innovate, to go to people's homes, to avoid them having to take time off work, to be available for them 24/7, to spend the hour, 2 hours, 4 hours we need really understanding a person's psychiatric history so we can help them apply for housing, because we know that the housing is actually the most important input to their well-being. We can do all of those things because we have an innovative payment structure that reimburses us for ultimate outcomes.
Thank you. Joe, a slightly different question. Zoom back for us. How does give us the epidemiologic view on this? How does the makeup of our healthcare workforce impact health outcomes?
I mean, going back to the points that were made, it is about the investment, because the investment allows us to build those relationships and have that accountability. I mean, I think, put simply, it's pay for relationships and outcomes, pay more, and pay easier. And, this issue of physicians being well compensated, it's all good. I think at the end of the day, though, we need to understand that there are individuals who are really committed to primary care who fundamentally cannot go into primary care because of the debt burden. Our tuitions in medical school compared to other countries, again, is 5x in some cases. So the amount of debt burden, and particularly when you're talking about diverse individuals, diverse backgrounds who want to serve their community, who are forced to make not basic choices, but life choices, survival choices in many instances. And so, I think this investment piece is really, really critical. And I think as we consider how important primary care is, there is a graveyard of all the proven interventions to do everything that Toyin just said, but it has just not been built into the way we finance our healthcare system and our lack of priority on primary care. So whether it be community health workers, navigators, healthcare coaches, advanced practice practitioners, it doesn't just need to be primary care doctors. On top of the fact that clearly when you think about the fact that if somebody goes to a health center today, health centers, major providers of care for vulnerable communities. We just did a site visit with my team to one of my colleagues up in Spanish Harlem. Because of the billing issues, he can have a patient come in for a primary care visit, but he has to have that patient schedule another day for an oral health visit. I mean, the root of this primary care kind of idea of community health centers is one-stop shop. You take that one day off, you kind of come in, and he can't create a sustainable financial model because of this kind of, well, sorry, I can't see you for 2 things today because of the charges and the way this is going to impact our bottom line. So, there's a lot of these low-lying fruit that we need to take off the table. But fundamentally, there is no shortage of answers here. It's just shortage of will, and I would argue, in many cases, the powers of the status quo keeping the investments as is. And it shouldn't be pitting doctors against doctors, as you said. It's no shade on anybody. But fundamentally, I think we can all do well and do much better as a nation as it relates to health and healthcare.
Mark, please.
Yeah, I'll just add, the average debt is above $200,000 coming out of med school. It easily is $400,000. And even students who have scholarships are often sending that money home to their families. The kind of doctors who we are trying to bring into medicine, as Toyin and Joe just said, often there is no money at home. They are the first to go to college. It's amazing given the communities they came from where no one goes to college. There are no role models. They've never seen a physician who looks like them, but they had that drive and they had that spirit and they got themselves into college and then they got themselves into med school, but there is no money and they are doing everything they can and they become the ones responsible for their families. So I just want to echo why it is that we're hearing that, how can doctors not afford to pay back their loans? It really is challenging for many of them. And then I'd say at our school, to build on something Toyin said, we teach our students that what goes on in the home, in the workplace, in the school, in the neighborhood often has so much more effect than what we can do in the clinic. And that we as physicians need to be taking the time to learn what's going on in our patients' lives, learn their values, learn how they're discriminated against, learn all the challenges that come with the settings they're in and work with them, whether directly through the groups that we have in our office with social workers to help them seek services or connect them to services in the community. But we are not, at least in my view, this is a personal view, we are not doing our full job in looking after our patients' health if we are not aware of and engaged in what's going on in their lives. And in terms of patients feeling comfortable coming to our practices, feeling like it's an inclusive environment where they are seen and heard and welcomed for who they are, the last thing we need is patients code switching when they come to the doctor. Asking these questions will help them feel more comfortable, really revealing who they are to us so we can provide them the best care possible.
Can I say one thing? Everybody talks about integrating X into primary care. Let's integrate it because it all makes sense, right? So now I ask about, about guns. I ask about social needs, mental health. The list goes on. Mm-hmm. The time does not expand. The administrative burden is large. I want to do it. The moral injury comes from the fact that I simply can't.
Yep.
And I see it every day. And I know I have someone in front of me that in many ways I could help if we strip away the bureaucracy. And in some ways I can't help because we haven't invested in public health. And so this is where we are. And I think I laud efforts to, around integrating into primary care, and you hear that a lot. But I say, boy, if we're going to integrate more into primary care, we really need to change the way we prioritize and invest in primary care, because we're up for it.
Yeah.
We're up, and we have the teams to do it.
Yeah.
But that lack of investment makes it untenable. Not to mention that big health systems are really underinvesting, quite frankly, right now in primary care, with the shift towards specialty care and higher margin. Again, that's evidence. It's not a judgment call. But I think we as a nation need to say, is that the right deployment of those resources?
Thank you. We're going to move on. Primary care evolves. Second topic that I want, and you guys have already talked about this. We've done a lot on current state. Where are we headed? Bottom line has come up a few times. Payment, who's going to pay for the increased salaries, has come up a few times. I'm wondering, I see in my own clinical life, I work often with mid-levels, ARNPs that are very skilled. We talk a lot about scope of practice. Is the solution, if we can't bring more primary care MDs back into the fold, is it mid-levels? Mark?
I think that's what we've been trying to say, or at least I have, maybe not as articulately as we needed to. We need groups. We need groups that include all levels. I don't really view it as low, mid, and high, but I realize societally we view physicians at the top of the chain. But we need physicians, we need nurse practitioners, we need physicians associates, we need the community health workers, we need the social workers and the psychologists and the pharmacologists, which I say particularly for your job. We need them all working together so that, no, Joe, of course, cannot spend, although Joe's pretty good, but he can't spend all day asking about every possible risk. But if he has a physician's assistant who is nurturing and communicative, that person can do a lot of the pre-screening, certainly in pediatrics, all of the developmental screening, the screening for autism, the screening for ADHD. All of that can be done by a really skilled physician's assistant so that when the pediatrician is spending the time with the patient, it can be more focused. So yes, I absolutely support what I think you're asking, that we need teams to work together. Would I like to see more physicians going into primary care? Absolutely, but we can't wait. And we also have a nursing shortage, but we need to train up people in all these roles and have everyone financially enabled to work together.
Toyin, how do you think about this at CityBlock?
Oh yeah, strongly agree. I think it's interesting to see a lot of physician professional organizations wringing their hands about the rise of advanced practice clinicians, and so by that I mean nurse practitioners and physicians' assistants and associates. I think it's wrong-headed. I think we're totally missing the point here. There's not a world in which, with an aging population that's getting sicker, with more and more complexity in our clinical milieu. We have more tools, but we also have more diseases that we need to solve for. Honestly, frankly, with the impact that poverty and inequality has on increasing levels of morbidity, particularly when you think about mental health and substance use, doctors are not going to be out of business. There is more work than we can do. And so we need to embrace the fact that there are so many other incredibly skilled and licensed professionals who are part of the solution for us. We actively embrace advanced practice clinicians. They play such an incredible role. Start with nurses. It's not that they're a substitute for physicians. They're trained differently. A nurse practitioner, it's been proven in data, is better at a number of primary care functions than most doctors. So why are we not using them? Why are we thinking of them as substitutes for physicians reluctantly? Why are we not saying, actually, this is a role for an NP? Our home visiting teams are anchored by nurse practitioners, and they're phenomenal at them. We leverage physicians' assistants. We leverage community health workers in tremendous ways to build relationships and provide that bridge to care. I found that EMTs and paramedics who are ready to come off the fast life on the 911 train and actually take their skills into the home, into the community, they're excellent at triage, at working with limited resources, at building relationships very quickly in an urgent setting. They're wonderful at communicating with physicians and partnering across. We use them in our model as well. When we stop thinking that the pie is limited and that we are fighting with each other for resources, and start to realize that we can make the pie bigger, and in fact we must, because in order to serve the people that we need to serve, we have to think about a much more asset-based, much more sort of abundance-based philosophy around this. The tent is big enough for all of us, and in fact, we need all of us in different ways to play different roles here. Then you start to really get these incredible interdisciplinary teams that flourish. I think the other thing that I feel is a real source of pride for us at CityBlock is we do case conferences and daily huddles. So the entire interdisciplinary team every day gets together, and they look at data. We look at who was in the hospital yesterday. We look at who are our folks who are struggling with needs that we haven't quite met yet. We look at who did we get phone calls from overnight who might need a follow-up visit. We look at all of the data that we can together, and we make plans. And we bring in the patient and their family, and we do case conferencing with them. And one of the things that I always find so special is if you were to observe from above the room, if you look at how much time people spend talking, you look at what people are wearing, you look at the sort of the body language that goes on in the room, you wouldn't be able to tell who the doctor is and who the community health worker is or who the pharmacist is, because we're all equals. We're professionals working together on the same problem. Everyone has a role to play, and we've got to get rid of the hierarchy. I haven't worn a white coat in I can't remember how many years. We don't have them in our clinics. There's no room that the doctors go hide in to chart. Everybody has to work together, and we've got to figure out ways to break down those silos.
Joe, here, absolutely. I'm going to pivot, Joe, for you.
Yeah.
And I want you, we're in an election season.
Yep.
Commonwealth Fund is an organization we look to for guidance and just to give us a North Star. And where are there policy gaps? What are we not talking about at Capitol Hill that we should be talking about? What are your wish list of policy priorities? Maybe give us a few that we should be talking about.
Absolutely. And I'm hopeful. I think we shouldn't end in a place that doesn't provide hope. I think we're all eternal optimists here. That's why we stay in the work that we do. And ultimately, I am hopeful. There are legitimate bipartisan conversations happening around a couple of different areas that are important. Certainly, this greater investment in primary care and payment reform, moving from fee-for-service to value-based payment. Senators Cassidy and Whitehouse come together on the Senate side. Senate Finance Committee is looking at ways to increase payment for primary care providers. I think that's very, very important. And so that's real and that's happening. And the fact that it's bipartisan nowadays is like a miracle, right? So to find anything that there's a real sense of a connection on. I think there's a real acknowledgement that we need to do more by way of workforce. I think there's also bipartisan energy around that, not just physicians, team-based care, nurses. And just as a quick exit ramp, I say we need to communicate this to patients and to people as well, because we still have a lot of patients who say, I want to see the doctor, not the nurse practitioner. Right, so we need to come together as an industry and say, look, we are all healthcare professionals. We are setting you up with the best person who will meet your needs, and we're all working together. So workforce is another one. And I think just greater investment and kind of readjustment around primary care, health centers, loan repayment. A lot of things that we're talking about here are actually being discussed and I think in many ways being moved forward. It requires a lot of our engagement, and I'd say the one thing that is missing, there's no doubt that many of us are frustrated as providers, as people who see what that North Star can be. But I would say that every day when I see patients, the amount of frustration, the amount of confusion, the amount of dissatisfaction with just access to primary care is at new highs. We have not done a good job of catalyzing that frustration for more advocacy and political action from people, from constituents, to add energy to this fire. Because clearly we could be talking about it, but it is when people say, I can't see a primary care doctor for 3 months. I can't get care. I can't get a call returned. That is the energy. I think that's the one piece that's missing, and I think that's the part that we want to focus on, especially when we think about politics and policy.
Thank you, Joe.
Can I add to that a little bit? I'm just maybe a shout out to Natalie Davis, who leads an organization called United States of Care. They focus on research, really, from the voices of Americans across the country about what they want from their healthcare system. And I was asking her this question yesterday. I said, look, we all know it's broken. We all feel how badly our primary care infrastructure, our healthcare infrastructure in general, is caring for people. Why aren't people voting on this? And she said that on the basis of their research, what they find is that people don't think it could get any better. their expectations are so low that folks are afraid of rocking the boat because they feel it could get worse. And so I think in addition to everything you said, Joe, I think one of the things we have to do as healthcare leaders is also express our optimism. We have to tell people that they can dream and hope for more, that they cannot just focus on, you know, if I've got this one doctor who I've known for my whole life and they actually do answer the phone and I don't want to rock the boat. If they can aspire for more, we can collectively aspire for more. And if we as the leaders in the system who know it the best can say, guys, it can be better, hopefully we can then catalyze a sort of broader societal movement around saying, okay, let's make it better now. Because it was so depressing to me to hear that, that, you know, people will sit down and complain for hours about their healthcare, but when push comes to shove, they're so afraid that it could actually get worse that they're not willing to push for any change.
Yeah, just one, if I could just add one other thing I learned from Natalie yesterday, which is fascinating for me because we've been pushing value-based care. She said in focus groups, people don't want value. It's like the value meal. And like, I don't want, right? Like, I don't want the budget healthcare. Like, I don't want value, like the value deal.
They already feel like we're skimping on it.
And I was like, wow, you know, here we are talking about value-based care and value. And to us, it means something. And to them, it's like, I don't want the value-based meal. I want the, like, you know, I want like a meal. So anyway, sorry, Mark.
Yeah.
Sure. Anyone here in marketing, we can use some rebranding.
Yeah, seriously.
We need to change value.
The session right before us was Chiquita Brooks-LaShore, who is the administrator for CMS, overseeing Medicare and Medicaid and other programs. And first of all, it was fantastic. If this is taped, watch it. But she actually talked exactly about all the efforts that she and her team are making to really change how we finance and really move more towards value-based care that'll be renamed.
Whisper. You got to whisper it.
Yeah, whisper. But then the other thing I wanted to say, and this is a little bit going off in a different direction, but I think it shows how everything is interconnected. If I have the chance to talk to a policymaker, and I'm not representing Kaiser Permanente or a school right now, I'd say give us paid family leave. It is so horrifying to see children lying in a hospital bed, petrified at 4 years old. There are scary bells, there are needles, they're all alone because their parents can't be there. They'll get fired from their jobs. And I also think that no one should be going to the doctor, certainly not if you have serious symptoms, without a family member or friend. You're not going to remember half of what was said. You need your advocate with you. And if you don't have someone, that's another reason we need social workers and care coordinators in the practice. But I think that paid family leave is viewed as a labor issue. It's a health issue, and we need to enable people to not get fired because they get sick, their family member gets sick, and they can't even go to the doctor with their family. So just wanted to make a plug for that.
Yeah.
Okay, we're here at Primary Care Evolves. We're going to wrap up this portion pretty soon, so if you have questions, we have mic runners coming around, please do ask them. I do want to close, maybe keep it to 60 seconds each. What are you hopeful about? Toyin, let's start with you.
Well, I'm hopeful about these conversations. I'm hopeful about the fact that we're building coalitions, first of all, that understand that one size doesn't fit all in primary care, that we have to think about our populations holistically, but that ultimately our goal should be to personalize care for individuals, particularly those who have the most complex needs, the most to lose and to gain from our healthcare system, and that we're starting to do that. We're starting to see opportunities for companies and organizations like ours to grow and to scale, and that gives me a lot of optimism that we hopefully will start to create the blueprint for what the rest of primary care can start to look like over time.
Joe?
I think similarly, the type of progress we're seeing around these key areas that we believe will be fundamental in advancing primary care is heartening. I do worry that if we don't take that to its rightful conclusion and do it the right way, we can take steps forward that then, allow the whole thing to blow up. By that I mean, if we say, okay, we're going to invest, but it's going to be just this much more, but we invested, that's not going to get it done. So I think this advocacy piece is going to be really, really important. And I like to leave everyone with a to-do, which is really think about ways in which we all can lift up the importance of primary care. And it will evolve. And I mean, it's evolving. It's evolving. I think we just need to have the resources to allow people with innovation, creativity at the kind of heart of what they do to be able to do it and do it well.
That's great.
My optimism comes from our students. Every day I go into work. We're a brand new school. We just graduated our first class a few weeks ago. We got accreditation this week as I promote our school. And let me say, our students are amazing. They are earnest, they're smart. All med students are smart, but they are compassionate, they're energetic, they're engaged in what's going on in the world, they're committed to health equity, and they're just really excited to be doctors and really excited to serve patients. And I don't think it's just the students at our school. I think our students are special, but they have friends everywhere who are just like that. They are eager to change the system. They're angry at us for screwing up climate crisis, and they're aiming to fix it, rightfully angry at us. And they have this spirit of, we are going to fix it. And maybe it comes from social media and they know people all over the world, but whatever it is, they have this confidence and this passion that really gives me hope. And so please do not leave this session with any pessimism. You've heard 4 people, if I can include you, Vin, who really believe that we can make things better, and there are great people out there trying to do that.
Here, here. Oh, well, gosh, we are seeing lots of raised hands here. So I think we have our mic runners. Let's go right over there. Perfect. I think we have the mic coming right to you. And we're going to try to hit maybe 5 questions.
Hello. Hi, everybody. My name's Erin Broadwin. I'm a health tech reporter. I cover the business of health tech. On a less serious note, we should maybe call it like quality-based care. On a more serious note, part of the problem here is obviously that the profit incentives are not aligned in the right way. They are not aligned for value or for quality. They are aligned for profit. What are you all seeing as the most promising avenues toward profitability, or at least break even, in terms of getting to this place where primary care can do more, where we can incentivize value-based or quality-based care, where we can incentivize longer visits, where we can incentivize more of a wraparound holistic model?
Channeling Natalie. So apparently her research on the nomenclature shows that people want it to be called person-centered and personalized care. That's what that resonates for folks. So we should all take that as a nugget, and check out their website for more information there. I do think that we're seeing small pockets. I would sort of count us as one of them, of companies that have been able to find a way to align the profit motive with person-centered care, with investments in primary care and mental health and social supports. Certainly CMS and CMMI within CMS has been really pushing alternative payment models that are intended to create the right incentives for this type of work. But the reality is that that's one small part of the overall piece of the way that we pay for healthcare. And until we can start to get real momentum to shift towards that direction, I think we're going to continue to see a lot of really unfortunate examples where the profit motive doesn't align with better outcomes or with innovation and investment, particularly in marginalized communities. And so, I think the upshot, and Joe will probably want to add on to this, is that I do think that there is bipartisan support for increasing investment in value-based or value outcomes-based care, but it has been slow to take off. We've been having the same conversations about this stuff for 10 years. Progress in healthcare is incremental, but I think there's a lot we can do as informed consumers and as healthcare leaders to start to continue to push that momentum in that direction.
Joe, maybe a quick word, and then let's get to more questions.
Yeah, I would just add, there's no doubt that there's a real concern around this pendulum swinging around profits over patients. I don't begrudge profit. Show me better outcomes, better health outcomes, and we could be on our way. The evidence is not demonstrating that in many, many areas. We have actors that I think, need to be interrogating, need to be looking at, and whether it be private equity, we talked about consolidation yesterday. Again, this isn't a judgment call. This is an interrogation of these major actors in healthcare, whether it be non-for-profits and their behavior as truly non-for-profits or not, whether it be large payers, and whether it be some disruptors who are not traditional healthcare players and entering the healthcare space. I think as we think about these big actors, we need to be asking these hard questions. And again, for me, I don't begrudge. We've chosen a way that we kind of form a market-based healthcare system. We could debate that. It's what we have. If you're making profit and you're demonstrating incredible health outcomes, I have no problem with that. If you're falling short, I have a problem with that. And I think we have a lot more problems than good stories right now, and this is the conversation we need to be having.
Great. I think we have a few. Let's go to this gentleman right here in the middle of the aisle, if we could. Yeah, perfect. Perfect.
How you doing? I'm James Corbett, a former healthcare exec, or recovering health exec, if you will. Question around that, the health system. So health systems have do what they call vertical integration, buying physician practices. Studies show that they have lower quality and higher costs. At the same time, Optum, a subsidiary of United Health, owns the most physicians in the country, over 90,000. So it's a bit of a softball for you, given your model, Toyin, but we can unpack it. I want to understand how it is, because when I was at exec, we would call it a physician box, where you put a physician in the box and you make sure that they don't get some decision making, because we know that their challenges at conflict of obligations, obligations to their patients and the obligations to the system. So how do we unpack that? The horse is out of the stable in some respects, maybe too hard to take it back, but what can be done?
You want to grab it?
No, you get that one. I'll get it with you. I'll get it with
I'm looking at the healthcare execs here in the room. I'm like, you want me to walk into this one?
No,
I'm all right. No problem, James.
I'm with you. I'll walk with you.
Okay, good.
We'll hold
We'll hold
hands.
hands and
Yeah,
walk
let's
in.
do it.
Here's what I think, and you know, I welcome feedback. Here's what I think. I think that this is not a monolith. Academic medical centers, the large research institutions, have over time seen value in aggregating primary care. Many of them are not-for-profit institutions. Many of them think of primary care as loss leaders, but they help refer into their specialty systems. And that's how the economics work there. I actually think this is interesting, right? I think there's something we can work with here. Why? Because we need those academic institutions, these centers for excellence, these tertiary and quaternary centers. We need them. We need them in each community, frankly. We need access to them in many of our communities. We need them to be financially viable. Where I struggle is your point around quality. And the fact that today the economics do not incentivize investing in those primary care boxes, if you will, because they will often, into the long term, continue to be loss leaders relative to the big capital expense of managing these institutions. We have to change that. I think there are ways to change that with leadership and vision that don't require cutting into the bottom line, but do require these health systems to be major players in value-based care. They also have to say, we're going to think about ways to contract differently with health insurers. We're going to think about ways to contract differently with Medicare through the MSSP programs and other ways to tie through ACOs and other structures like that. They have to be willing to make investments in population health, in care coordination, in community-based supports. Many of them have large community benefit funds. They need to have concerted strategies around how they invest in the communities around them. That's what I think is the answer for that bucket. When you look at the large for-profit aggregators of providers, there I think we have some different questions to ask. And I think these really, tie to sort of what is our regulatory framework and what's our tolerance for profit absent quality. How do we get the data so that we can actually answer the question, so we can ask fairly, are they delivering? And then how do we overcome a lot of the political barriers, lobbying, et cetera, and make the right choices around regulating these spaces such that we are holding them accountable to improving quality.
Just real quickly, the collateral damage of this is patients, it's people.
Yeah.
And fundamentally, it's a game and not me. Payers say, those hospitals are driving up prices. I got to increase premiums. Employers say, you're increasing premiums, okay. Hospitals say, we need to aggregate, we need more power to negotiate. And it is like, everybody's firing at each other. And we're not aligned around getting the health outcomes we need for the nation. And as a result, everybody's in their silo and firing off their shots. So it's a major problem. And I think unless we get better alignment, the not me phenomenon is very, very powerful in deflecting responsibility to the next actor in the play.
I'm going to,
please.
sorry, Vin,
No.
just add an extra sentence. The employers, the payers, the purchasers of healthcare. As an individual, I have no power. Maybe I can write a letter to the editor and it'll get read. But the large employers have enormous power if they want to assert it, as obviously does CMS, what we keep referring to, Medicare and Medicaid. They need to assert themselves more with the providers of care, with the insurance companies, to really make sure that, I mean, profit is part of our whole system, but that the profit does not come at the expense of quality, to repeat what was just said.
Yeah, just to plug, we have an employer-sponsored insurance task force. About 170, 180 million people get health care coverage through their employer. Commonwealth Fund has a task force right now that will release a whole set of recommendations around how employers could get more engaged and what we could do in that space.
That's great. We have time for one more quick question. Let's go with the highest raised hand right over there.
That is
Awesome, I win. Exciting. Hi, I'm Jackie Gerhardt. I'm a family medicine physician, and I'm Chief Medical Officer at Epic. And I'm curious what you're all going to do. You mentioned the small pie and kind of elbowing people out. I agree. I hate the term mid-levels, and I want us all to come together as a team. You mentioned making the pie larger. What if you think of it as a potluck, and you have, multiple different people coming to and setting the table for all the things that every person needs. And then you think of the person-based care coming to the table and choosing what they want from the potluck. How can you center all of that around the patient? Epic makes my chart, for example. Could the patient just fill out their own stuff? Could they use that more and leverage themselves more? Could they be more empowered so that there isn't so much elbowing of how many people in the care team are taking pieces of the pie, but that it's actually someone sitting at the table and choosing what they want? And furthermore, how can we use AI or technology to empower that as well?
I think we have time for maybe one response here. Mark, do you want to take this? And then.
Sure. So I want to make sure I really understand what this potluck is all about. But what I'd say is, I think patients should have access to their medical record. I think they should be able to see what's there, and they should be able to take it with them wherever they want to go. If they change physicians, if they change systems, they shouldn't lose access to all of that information. And I think that they should be able to access all sorts of health services without always having to go through a primary care provider. That said, I think the primary care provider, the primary care team is central, at least right now in the way I view healthcare, to having this patient have well-coordinated and high-quality care. I think that if what you're suggesting is that patients will decide, well, I have some chest pain, I'm going to go to the cardiologist, then, you may have reflux, which is gastroenterology. You may have stress. You may be having panic attacks. So that's why I wasn't sure what you're suggesting, but I still would like, I think we are all better off if patients, if we, our families and friends, have primary care teams that will really coordinate and be the point of entry so that patients know and understand and are educated. They do come in with reams of paper nowadays, printed off the internet. And I think that we will be better off if primary care is still at the center of things.
Great. I sadly have to cut us off. This was a great, engaging discussion. Toyin, Joe, Mark, thank you so much. Thanks all for being here.
Thank you, Ben.